Okay, good evening all. Today is the fourth session. So I'm going to talk about neurology and therapeutics and toxicology. So we will be covering this topic includes 35 questions out of 200. So from neurology there will be almost 17 questions, and from therapeutics and toxicology also there will be 18 questions. And these are the topics included in neurology. Main topics, that is stroke, headache, epilepsy, movement, neuromuscular disorders, central cord disorders, that is spinal cord, and from therapeutics, adverse drug reactions, pharmacokinetics, dynamics, poisoning, antidotes, therapeutic drug monitoring. So from neurology, this is a basic approach, that is, one second. If there is a coordinator, please admit everyone who's coming. So from the neurology, first we have to understand how to localize. That is, from the we know the localization starts from the cortex, from to the brainstem, then spinal cord, root, nerve, neuromuscular junction, muscles. So you must understand how to localize first, and by reading the scenario, whether it is UMN or LMN. UMN, we all know it is spastic, hyperreflexia, upgoing plantar. LMN is flaccid, areflexia, and wasting. And the time course also matters. If it is sudden, most probably it is vascular. If it is subacute, usually it will be inflammatory or infective. And if it is chronic, it is usually degenerative. And these are the main topics, that is the CVA, status epilepticus, subacute hemorrhage, GCA, that is giant cell arteritis, and cord compression. So stroke. Stroke means, the basic thing we have to understand is that we need non-contrast CT first to exclude hemorrhage. So first investigation, if they are asking what to do when a patient comes with a scenario of like CVA, the first investigation is non-contrast CT. First we have to rule out whether there is bleeding. After that only we can move for whether we can give thrombolytic therapy and all. So first we have to do non-contrast CT, not MRI. And the second is whether then we have to rule out ischemic or hemorrhagic stroke. If it is ischemic, and if it is within the time period, that is within the 4.5 hours, we can give thrombolytic therapy. Up to 24 hours, we can consider for thrombectomy. And if it is hemorrhagic stroke, the first management is reverse anticoagulation, control BP. Then secondary prevention comes later. We have to give antiplatelet, statins, BP control, and carotid imaging. Carotid imaging is very important part in MRCP part 2. They will ask when we will give carotid endarterectomy, at what percentage we have to study by heart. And localization, as we all know that anterior cerebral artery covers the leg part, middle cerebral artery covers the face, arm, and dysphasia part, and posterior cerebral artery covers our visual cortex part and brainstem. This is the acute stroke pathway. The first immediate investigation is non-contrast CT head, and we know that main two types of stroke, ischemic and hemorrhagic. Ischemic, as you all know, less than 4.5 hours, it is thrombolysis, and hemorrhagic, it is reverse anticoagulation. And if it is large vessel, we can consider for mechanical thrombectomy. This is a scenario. A 68-year-old presents 2 hours after sudden right-sided weakness and expressive dysphasia. BP is high, glucose is normal, non-contrast CT shows no hemorrhage and no established infarct. What is the management? Option A is aspirin. Option B is IV thrombolysis. Option C, wait. D is warfarin. E is BP control. So what do you think in this scenario? Here it is an ischemic stroke. There is no hemorrhage, there is no bleeding. and it is within the window period. So we can go for thrombolytic therapy. This is the answer. IV thrombolysis within 4.5 hours, CT excluding hemorrhage, and confirm there is no other deficit, we can directly go for thrombolysis. Also, there is one thing is that we have to take history whether there was any contraindication for thrombolysis. But here it is a straightforward question. There are no other options, confusing options, so go for thrombolysis. Here aspirin, there is a trap here is that aspirin, once we have thrombolysis, never start aspirin immediately. Aspirin is started 24 hours after thrombolysis. Now, the other part other than stroke we have to study is the transient ischemic attack. Transient ischemic attack is transient focal neurological deficit without any infarction. So, it is a high predisposing factor for immediate stroke. So, we have to give immediately when the patient complains of like she had deficit but now it is resolved. We have to start on aspirin and we have to put it up for urgent specialist review. And we have to do imaging, and here comes the importance of carotid Doppler and see how much percentage is affected. Then go for endarterectomy. A 70-year-old had 30 minutes of right-sided arm weakness and dysphagia that fully resolved. He is in sinus rhythm. Carotid Doppler shows 80%. So that percentage is important. It is 80%. So almost the cutoff is 50 to 70%. More than that, we can go for carotid endarterectomy. So here answer is option B. Symptomatic and severe. That is, severe is more than 50 to 70%. We can go for endarterectomy, which reduces a recurrent stroke. Anticoagulation is for cardio, and pure anticoagulation, that is warfarin, is for embolic sources, not large vessel stenosis. Now this is a third important topic, headache. There are different types of scenarios. The first one is thunderclap headache, which is seen in subarachnoid hemorrhage, giant cell arteritis, raised ICP, venous sinus thrombosis, and meningitis. These are the 5 basic differential diagnoses in severe headache. So subarachnoid hemorrhage is sudden worst ever headache. So the first investigation is what? CT. If it is negative and within the window, that is 12 hours, within the 12 hours, we can go for a lumbar puncture to look for xanthochromia, but we have to do CT. The second is giant cell arteritis. We have to suspect age more than 50. If there is a jaw claudication pain, raised DSR, the first management is steroids. Then only go for biopsy. Why we are giving steroid is that it is just to protect the vision, because anytime the vision can go for ischemic arteritic optic neuropathy. Then third is migraine versus cluster, that is cluster headache. Migraine we give triptans. In cluster headache, the treatment is high flow oxygen. The last one is idiopathic intracranial hypertension. So by the basic appearance of the patient, we can understand young obese female with papilledema. They will complain of blurring of vision. If we have a fundoscopy, we have to look for papilledema. Also, we have to look for sixth nerve palsy. Sixth nerve palsy, that is a false sign. We have to look. Then immediate treatment is weight losing and acetazolamide, not lumbar puncture. So these are the main differential diagnosis: subarachnoid hemorrhage, CT, then lumbar puncture for xanthochromia, giant cell arteritis, steroids, raised ICP, imaging to rule out coning, venous sinus thrombosis. We have to go for venogram. A 45-year-old describes a sudden severe occipital headache being hit from back with neck stiffness and vomiting. CT head 8 hours later is reported as normal. So what is here? There is sudden severe headache and CT is within 12 hours and it is normal. Now we can go for lumbar puncture. So thunderclap headache with a normal early CT, we can go for lumbar puncture to detect xanthochromia. The CT sensitivity falls after 6 hours, but we cannot discharge a patient based on normal CT. We have to do lumbar puncture. A 74-year-old has a new temporal headache, scalp tenderness, jaw pain. ESR is high. So here the answer is B. Start high dose prednisolone and then biopsy. This is epilepsy. Epilepsy, first seizure, we have to exclude provoked causes like hypoglycemia, hyponatremia, alcohol intake, drugs causing hypoglycemia, infections like malaria, structural diseases causing the first seizure episodes. What is status epilepticus? That is any seizure which is lasting for more than 5 minutes or recurrent without any recovery. So the first treatment is always benzodiazepines. IV lorazepam or buccal midazolam is the first treatment. What is the second treatment? Second treatment is also the same thing, that is benzodiazepine. So twice we can give benzodiazepine. The third time only we can choose for the second line options like IV levetiracetam or phenytoin or valproate. And refractory cases, we go for ICU, intubation, general anesthesia, and further we have to check for the first causes. So here, the last line you can see benzodiazepine first. Again, we have to check glucose, and if the patient is taking any drugs like isoniazids, we have to give pyridoxine. So this is the first step. First, airway, breathing, circulation, oxygen, glucose. First, we have to check IV access. First is IV lorazepam. Again, repeat benzodiazepine. Then only we have to go for IV levetiracetam, phenytoin and valproate. Lastly, we have to, if it is refractory, nothing is acting on the patient. If it is refractory, we can go for intubation and anesthesia. A patient has been convulsing for 8 minutes. Airway, breathing, circulation is managed, oxygen given, glucose normal, IV access is obtained. He has already had 1 dose of IV lorazepam. What is next? It is within the first 10 minutes. Within the first 10 minutes, twice we can give benzodiazepine. So the answer is option B. Repeat benzodiazepine. That is the first drug itself. Then only we can go for second line. Movement disorders include Parkinson's disease, Parkinson's plus disease, drug-induced tremor, Huntington's chorea. Parkinson's disease means asymmetrical resting tremor, bradykinesia, there will be rigidity. The treatment is levodopa. Parkinson's plus is supranuclear palsy, then multisystem atrophy and Lewy body dementia. In this, there will be other symptoms like cognitive fluctuations will be there in Lewy body dementia. In MSA, there will be autonomic failure, that is postural hypotension will be there, and PSP, there will be fall. Drug-induced, these are the drugs which is causing Parkinson's-like features, antipsychotics and metoclopramide. Tremor. Resting tremor is seen in Parkinson's, and postural tremor is seen in essential tremor. Intention tremor is seen in cerebellar disorders. Huntington's chorea is a movement disorder. There will be having associated cognitive, that is memory loss, and it is an autosomal dominant disease. Essential tremor. Essential tremor is usually improved by taking what? Alcohol. And there will be usually a positive family history. And it is usually symmetrical. A 68-year-old has a 1-year history of an asymmetric resting tremor. slowness, that is bradykinesia, shuffling gait. There is rigidity, reduced arm swing on the right. So here it is what? Idiopathic Parkinson's disease. Idiopathic Parkinson's disease. The triad is important. Resting tremor plus bradykinesia plus rigidity. Now it is neuromuscular disease. The 5 basic disease you have to study is motor neuron disease, GBS, myasthenia gravis, myasthenic crisis and myopathy. Motor neuron disease is mixed. There will be mixed UMN plus LMN signs without any sensory loss. Riluzole is just a drug we are giving, but it is not an therapeutic drug. It is just a supportive drug. But only drug available for motor neuron disease is Riluzole. Guillain-Barré syndrome, it starts from lower limb. It's an ascending type of weakness. There will be areflexia. Usually it is seen post-infective like following GI infections and all. The treatment is IVIG or plasma exchange. The important thing in Guillain-Barré is monitor the vital capacity. Anytime they can go for respiratory paralysis. Myasthenia gravis, it is a fatigable type of neuromuscular junction weakness. There will be bilateral ptosis. There will be diplopia. The treatment is anti-cholinesterase inhibitors like pyridostigmine. We can also give immunotherapy. In myasthenia crisis, patient goes for respiratory failure. Once they go for respiratory failure, we can directly go for immunotherapy plus ventilatory support. And myopathy is muscle disorder that there will be proximal weakness, high creatine kinase. The etiology can be inflammation, metabolic or any drugs. So these are the localizing parts. In MND, the localization is anterior horn cell within the spinal cord. Here the sensory is not involved, only motor part is involved, that is both mixed and both UMN and LMN. If it is nerve, sensory is also affected. Neuromuscular junction, only muscle part is affected and is fatigable. Myasthenia gravis is fatigable, but LEMS is improving. LEMS is usually seen in part of paraneoplastic syndrome, usually small cell carcinoma of lung. So in whatever situation, if they ask like in GBS and all, the important thing is that there is a chance of respiratory failure. So forced vital capacity monitoring is very important. 2 weeks after a diarrheal illness, 30-year-old develops progressive ascending leg weakness, then arm with areflexia. FVC is falling. What is the treatment? Immunotherapy, that is IVIG or plasma exchange plus monitor FVC. B, option B. Here it is Guillain-Barré ascending type of weakness. A 28-year-old woman has fluctuating ptosis and diplopia that worsens towards, that is fatigable type of weakness. Anti-acetylcholine receptor antibody is positive. The diagnosis is myasthenia gravis. LEMS is the anti-VGCC antibody. Now this is demyelination disorders. Main important disorder is multiple sclerosis. The CNS, the brain is also, brain cortex is also involved. The usual investigation is MRI with oligoclonal band in CSF. MS, multiple sclerosis relapse, we give high dose steroids. We also give disease modifying therapy also. Cord compression is usually by external tumors. Usually we give urgent MRI plus or minus steroids. Then you have to understand what is cauda equina and cauda equina. Cauda equina means there will be saddle anesthesia, urine retention, areflexia. Then central cord. Central cord is usually different from cauda equina. Cauda equina means it is a peripheral group of nerves. So cord compression, that is a central part. There will be UMN signs below the lesion. There will be hyperreflexia because it is UMN. 1 second. So cord compression means it is a lower part. That is conus medullaris. So similar like the upper cord, it is a UMN type of lesion. There will be hyperreflexia, upgoing plantar, and there will be sensory level. So there will be bilateral spastic weakness. In cauda equina means it is the peripheral group of nerves. So it is LMN, reflexia, flaccid, saddle anesthesia, and urine retention. A 30-year-old reports a painful loss of vision in one eye with pain on eye movement weeks after a previous episode of limb numbness. MRI shows periventricular white matter lesions. CSF has oligoclonal band. So already mentioned multiple sclerosis. So there will be in every case of multiple sclerosis, the usual onset is from eye, that is optic neuritis, and there will be like the disease, like different types of disease will be there. Initially it will be eye, sometimes it will be the cord lesion. So there will be, if we take a detailed history, they will tell a prior neurological episode also they will tell. And MRI we have to take CSF, there will be oligoclonal band. Treatment is steroid. A 55-year-old with back pain develops bilateral weakness, numbness around the perineum, unable to pass urine with post-void residual urine. There will be, this is flaccid type. So what is the answer? It is usually cauda equina syndrome, because there is flaccid type of reduced anal tone, urine retention. So it is a cauda equina syndrome. So we have covered acute stroke, CT first, thrombolysis, less than 4.5 hours, once bleed excluded, thunderclap headache, exclude subarachnoid hemorrhage, first CT, then lumbar puncture, giant cell arteritis, steroids, status epilepticus, benzodiazepine, then also benzodiazepine, cauda equina, saddle anesthesia plus retention. The 32-year-old wakes with unilateral facial droop affecting the forehead, inability to close the eye and loss of nasolabial fold. There are no limb signs and rest of the exam is normal. So here is what Bell's palsy. Here forehead involvement is indicated, so it is an LMN type of lesion. If it is UMN, forehead is spared. If it is LMN, one eye is also involved, so we have to give lubrication plus taping. The young man is hit on the side of the head, briefly loses consciousness, has a lucid interval before rapidly deteriorating with a fixed dilated pupil. CT shows a biconvex hematoma. So biconvex hematoma is usually extradural hematoma, usually middle meningeal artery. For those who are thinking to go for PACES, you can join StudyMedic, because we have already planned to conduct MRCP PACES 2-day live on-site course, and also we have an offline course with mentor face-to-face mock session of mentor guidance with teaching. Now coming to therapeutics. Therapeutics first, pharmacokinetics, we have to study about the absorption, distribution, metabolism, excretion, pharmacodynamics, the mechanism, dose-response relationship, therapeutic index, interactions, poisoning, the specific antidotes, decontamination. Pharmacokinetics and drug interaction. The main important thing is we have to understand is the cytochrome P450 inducers and inhibitors. Inducers are rifampicin, carbamazepine, phenytoin, St. John's wort, chronic alcohol, which reduces the drug level. CY 450 inhibitors are macrolides, azoles, grapefruit, cimetidine, and valproate, which increases the drug level. Narrow therapeutic index drugs are warfarin, theophylline, and cyclosporin. Protein binding and renal clearance will change the drug-free level. Zero-order kinetics also we have to study in phenytoin and alcohol. Small dose changes can cause large drug level changes. This is cytochrome P450 inhibitors. Inhibitors will increase the drug level, which increases the toxicity. Inducers, which reduces the drug level. The patient stable on warfarin is started on clarithromycin for a chest infection. 3 days later, INR is high. What we have to do? So that is bleeding. Clarithromycin is an inhibitor. So we have to hold warfarin, give vitamin K. Warfarin we cannot give protamine. Warfarin we can give vitamin K. Now there are two types of adverse drug reaction, type A and type B. Type A is predictable, dose related. Type B is idiosyncratic, we cannot predict. Classic adverse reactions are like we know ACE inhibitors can cause cough, amiodarone can cause thyroid disorders, lung fibrosis, statins can cause myopathy, gentamicin cause ototoxicity, nephrotoxicity, skin reactions like Stevens-Johnson syndrome and toxic epidermal necrolysis. Then pharmacovigilance is a yellow card system. These are important medicines and the adverse reactions: amiodarone, thyroid plus fibrosis, ACE inhibitors, cough, angioedema, gentamicin, auto and nephrotoxicity, statin, myopathy, sulfonylurea, hypoglycemia. A patient on long-term amiodarone develops progressive exertional dyspnea and dry cough. Chest X-ray, there is interstitial. So here there is interstitial lung disease as a part of medicine. So it is amiodarone pulmonary toxicity. So we have to stop the drug. These are the common poisoning: paracetamol, salicylate, tricyclic, opioids, and activated charcoal is the usually given treatment. Paracetamol, NAC is given immediately. Salicylate, it is an alkalosis. The thing which is happening in the body is respiratory alkalosis. So we have to give fluids and alkalinization. Tricyclic antidepressants, we have to give IV sodium bicarbonate. Opioid, we have to give naloxone. Paracetamol overdose, if it is more than 4 hours post-ingestion, we can give N-acetylcysteine. Even more than 8 hours, we can give N-acetylcysteine. A 19-year-old took 30 paracetamol tablet over 12 hours. She presented 8 hours after the last dose asymptomatic. The time level cannot be interpreted. What to do? So, however, the patient had taken staggered or late overdose, we can give NAP. A patient who took an overdose has tinnitus, hyperventilation, sweating, and confusion. There is respiratory alkalosis and metabolic acidosis. Salicylate level is high. So the answer is IV fluid plus urine alkalinization. Salicylate toxicity, there is mixed disorders, there will be tinnitus. Opioid poisoning, usually we get pinpoint pupil, low respiratory rate, we have to give naloxone. Anticholinergics, because dilated pupil, the patient will be hot, deliric, mad. Cholinergic symptoms are bronchoria. We have to give atropine in OP poisoning, organophosphate poisoning. Sympathomimetic, the pupil will be dilated, agitation and tachycardia. Carbon monoxide, there is cherry red poisoning. The treatment is hyperbaric oxygen. This is a summary. Opioid poisoning, pinpoint pupil, anticholinergic, dilated, hot, dry. Cholinergic, small pupil, bronchoria, that is wet. Sympathomimetic is dilated pupil, heart rate and BP is high. Paracetamol, antidote is NAC, opioid, naloxone, benzodiazepine, flumazenil, beta blockers, glucagon, insulin, iron, desferrioxamine, digoxin, digoxin specific fragments, warfarin, vitamin K, organophosphate, atropine plus pyrrolidoxine. A farm worker presented with meiosis, profuse salivation, lacrimation, urination, diarrhea, bronchoria, muscle fasciculation after spraying. So what is this? Usually organophosphate poisoning, we give atropine. So carbon monoxide, there will be headache, nausea, confusion, false normal SpO2. In this patient, we have to check ABG. Then only we can understand correct value of saturation. We have to also look for carboxyhemoglobin level. The treatment is high flow oxygen or hyperbaric oxygen. Iron poisoning, we have to first clear the stomach, wash, then treat the shock. Then we have to give desferrioxamine, chelating agent. Beta blockers, we can give glucagon. If it is causing hypoglycemia, we can give glucagon. Then we can give high dose insulin. Lithium toxicity, we can give fluids plus last dialysis. Methanol or ethylene glycol poisoning, we can give fomepizole and dialysis. A family presented in winter with headache, nausea, dizziness, that improves when they leave the house. SpO2 reads 99, but that is false. So here it is carbon monoxide poisoning. Now coming to drugs where we need therapeutic drug monitoring. That is digoxin, lithium, phenytoin, gentamicin and theophylline. Digoxin, the symptoms are nausea, xanthopsia, arrhythmia. Toxicity is worse. We can give digoxin specific fragments if severe. Lithium, we can give NSAIDs, ACE inhibitors and thiazides. Phenytoin, the side effect is nystagmus and ataxia. Gentamicin, vancomycin also we have to monitor the trough level. Theophylline also, it is a very narrow index. So these are the treatment part, side effects and the drugs. An elderly patient on digoxin and a recently started thiazide presented with nausea, confusion, yellow tinged vision and slow irregular pulse. Potassium is 3.0. So there is hypokalemia. So here it is digoxin toxicity. Option is B. Treat digoxin toxicity with digoxin specific fragments. So cytochrome P450 inhibitors raise the level. Paracetamol, However, paracetamol, if the patient is taken, we can give NAC. Opioid, naloxone, organophosphate, atropine plus pralidoxime. Then beta blockers, glucagon, digoxin toxicity, correct potassium, lithium will worse. A patient who took tricyclic antidepressant overdose is drowsy with dilated pupil, flushed skin, and tachycardia. ECG shows broad QRS and patient is hypotensive. So tricyclic antidepressant overdose, I mentioned, the answer is IV sodium bicarbonate. A toddler ingests iron tablet and develops vomiting, hematemesis and shock, followed hours later by drowsiness and metabolic acidosis. Serum iron is markedly elevated. So iron injection, the answer is desferrioxamine. Activated charcoal we cannot give for iron poisoning because it will not bind iron. So these are the never things we have to keep in mind. Thrombolysis before CT excludes hemorrhage. No, it is first is imaging, then only thrombolysis. Then in GCA, first is steroid, then only go for biopsy. In subarachnoid hemorrhage, first is CT, then only LP. Paracetamol, anyway, how the patient taken, start NAC immediately. Then cytochrome P450 inhibitors with warfarin, we have to anticipate the interaction. Then digoxin, potassium hypokalemia will promote the side effect of digoxin. So these are the important parts in both topics. Neurology, these are the important thing: acute stroke, CT, thrombolysis, large vessel occlusion, thrombectomy, severe carotid stenosis, endarterectomy. Then thunderclap headache in subarachnoid hemorrhage, CT, then LP, GCA, steroids, status epilepticus, benzodiazepine, saddle anesthesia plus retention, corticosteroid, CYP450 inhibitors, toxicity, induces failure, macrolides and azoles plus warfarin, it will increase INR. Paracetamol, NAC, salicylate poisoning, alkalize the urine, dialysis if severe. Tricyclic antidepressant overdose with wide QRS, sodium bicarbonate. Opioid poisoning, naloxone, organophosphate poisoning, atropine. Multiple sclerosis, the lesions will be disseminated in time and space. Patients will have different types of lesion at different times. There will be CSF oligoclonal bands, GBS, and myasthenia. We have to monitor forced viral capacity. Myasthenia gravis, there will be ptosis plus. Also keep in mind LEMS. LEMS is seen in small cell carcinoma lung. Motor neuron disease, mixed LMN plus UMN. The drug we know is riluzole. Parkinson's is unilateral bradykinesia, slowness, rigidity. The Parkinson's plus also keep in mind, that is with dementia. Essential tremor is symmetrical. Treatment is not treatment, it is better with alcohol. Then beta blockers and calcium channel blocker overdose, glucagon, iron poisoning, desferrioxamine, carbon monoxide poisoning, high flow oxygen, toxic alcohol, that is methanol poisoning and ethylene glycol poisoning, fomepizole plus dialysis, lithium toxicity is worse with NSAIDs and ACE inhibitors. Phenytoin follows zero order kinetics. Activated charcoal, if we are giving, we have to give it in first 1 hour. This is sudden burst headache, subarachnoid hemorrhage, lumbar puncture, GCA, steroid, status epilepticus, benzodiazepines, saddle anesthesia plus retention, corticosteroid syndrome, fatigable ptosis plus anticholinesterase, myasthenia gravis. Staggered paracetamol or late NAC, pinpoint pupil, opioid poisoning, naloxone is the antidote. Sludge is organophosphate poisoning, small pupil, atropine plus pyralidoxime. Bradycardia, which is any beta blocker and calcium channel blockers overdose, glucagon plus insulin. Then winter headache is carbon monoxide poisoning. Whatever you are studying, please follow the NICE guideline. Okay. Thank you. These are the upcoming events. As I already mentioned, for PACES, live, both offline and online is there. Thank you.